Alright, so today we're going to be finishing up our lecture on artifacts, and we'll do a Kahoot review game. We'll really just kind of hit home all these concepts. So if you have any questions at the end of the day, please ask those, because our test is this Sunday on artifacts. And then, well, for procedures, we're going to be going over the lower extremity. So just let's start off with a quick review of the artifacts that we talked about last week. So the first one we mentioned was our phase mismapping, or ghosting. So on the exam, make sure you really know the first column, the third column, obviously the remedies, and then being able to identify what the artifact actually looks like on an MR image. So you need to be able to give several names of the artifact. So this first one, phase mismapping, is also called ghosting and motion artifact. So this mismapping happens on the phase encoding axis because this is the gradient that changes every TR period. So when we first encode the data, we select a phase encoding gradient that's either steep, shallow, or in between. And then the patient, due to involuntary motion, is breathing during our scan. They're not able to hold their breath for this particular scan. And that phase position has changed by the time that we actually record the data. So from here to here, we have gone from inspiration to expiration. So our phase location has changed, meaning that we're going to occupy a different row of K-space. So let's draw our K-space again. So imagine our K-space. Oh, that is not a rectangle. Usually we have more lines than this in K-space, but I'm just going to do a short little example. So what are the rows of K-space? Is that the phase or the frequency? Rows. Phase. So just a quick review on K-space. Remember, the top is always equivalent to the bottom. The right is always equivalent to the left. And the center of K-space is usually what? Our signal or our resolution? Signal. And then the periphery is our resolution. So imagine we select a shallow phase encoding gradient to start. So one of these that are closer, we don't need to apply as much amplitude to that particular phase encoding gradient. But due to the patient changing from inspiration to respiration, that phase encoding gradient was supposed to produce a phase shift that would cause it to go to 3 o'clock, but now it's gone back to 2 o'clock. So instead of filling this particular row of K-space that matched with the gradient, now it goes to, let's say, this row of K-space. So all the data occupies this row of K-space. And remember, the K-space is not our actual image. So we still have to go through one other thing. What is that computer Fourier algorithm, basically? So the fast Fourier transformation. So after the image, the K-space has been completely filled with all our data that we've collected, we still need to go through the fast Fourier transformation. And then what has happened is now the data is being allocated into a different pixel, and it streaks across our image in the phase direction, because that is usually the gradient that has kind of screwed up compared to our slice select gradient that turns on every RF pulse, and then our readout gradient, which is consistent. So the other two gradients are consistent, but the phase encoding gradient changes each TR period. So that's why the artifact streaks across in the phase direction. The phase direction, remember, is always our shortest axis of the anatomy. So here on this abdomen, you can see A to P is the shortest axis, So that's why they selected A to P to be the phase encoding axis. Okay? So you can see here how it gets that other name, ghosting, because it just looks like the abdomen ghosting across the image. Thank you. And then this comes from motion. So that's where it gets the other name, motion artifact. So here are some other examples. Here's where we're looking at the aorta. And remember, sometimes you can't completely compensate for an artifact, so you just have to basically get it out of the region of interest. So they were looking at the aorta, in particular the aortic arch. And so instead of having the phase direction going A to P, they changed it to go right to left. Even though it was streaking through the lungs, they weren't looking at the lungs. They wanted to look at the arch here. So now we're able to better visualize the arch. They were able to determine that there was a coarctation of the aorta here. Here's that motion artifact, patients wiggling in the coil. Our phase direction is right to left. This is a coronal image. So our right to left is the shortest axis. So this is the phase direction that it's streaking across. Here's an axial brain. Our shortest axis is right to left again. And this is our ghosting artifact. This one could really be remedied with our gradient moment nulling. So remember, it is motion artifact, but it's really coming from flow. So that is like flow artifact that could be remedied with our gradient moment nulling. Remember, it's basically balancing gradients that put that signal back into the actual vessel compared to streaking across our image. And then here's our C-spine. You could put a sat band. You could put the oversampling up and above. Have your phase direction going head to toe. And that reduces or completely eliminates that motion artifact coming from the carotids and the esophagus. And sometimes, in the abdomen, we can't really compensate for it, so what we have to do is use our respiratory compensation, where we image during expiration, and then we stop imaging during inspiration, where the chest cavity is moving. So we are just imaging during these times so that we don't get this. So we can use the bellows, or we could use that navigator where we put it right on the top of the liver, the dome of the liver, and image that way. And then we could also use sat pulses. So here, we did not use the sat pulse outside the field of view. So remember, we can have a sat pulse above and below, depending on if you're trying to eliminate flow from the aorta or the inferior vena cava. And this improves our image. The next artifact we talked about was aliasing or wraparound. So make sure you know that those are interchangeable. The main one we really talked about and want to highlight is our phase wrap, because the system really just eliminates this one. Okay? The system pretty much automatically compensates for it with this digital filter. It takes all the frequencies and eliminates any frequencies outside the field of view. It makes sure that we get adequate number of sampling, because we don't want that Nyquist theorem to have basically to encode the data incorrectly in the frequency direction by having an undersampling of the frequencies. So the system really just compensates for this. So you'll never really see this on the registry or anything like that, but it is possible if something is going wrong with the programming of your actual scanner. So if you are seeing wrap in the frequency direction, that could be an issue. You probably have to just call your engineer on that one. But your phase wrap, this is something that we need to be able to compensate for. So here we have the abdomen, and we have, basically the hip or basically the sides of the patient wrapping into our field of view. So basically, we are undersampling all the data that's underneath the coil. So that coil sits on top of the entire abdomen, right? So anytime you have a coil on top, and remember on the table you have the coils, so all that data still needs to be encoded in one form or another. So you could either increase your field of view. So instead of having a field of view that's not large enough to include all the anatomy, we increase our field of view to get all the anatomy. Or we could use phase oversampling and just put the oversampling on the side. What that's doing is really encoding all of those spins underneath those coils. So now that we are adequately sampling the data. So anytime we get phase wrap, we're undersampling the data in the phase direction. So here, we did not use a large enough field of view or phase oversampling, and the back of the head wrapped into the front. And that happens because the phase positions are typically similar to the ones on the opposite side of the anatomy. So these phase positions are duplicated on the opposite side of the anatomy. Right? So we have several examples of our phase wrap here. The most common one being that nose wrapping into the back of the head on the sagittal. This one is frequency of wrap, but remember the system should compensate for that. Here it's just saying that now we are adequately sampling the data. Here we only had phase encoding steps, like 16 of them. Here we've increased our phase encoding steps to double that because we're getting all the data now. This takes longer because, anytime you increase your phase encoding steps, this is your scan time. You have to basically fill all of K-space to finish a particular scan. So if you increase the number of rows, your scan time is going to go up. That's why it's part of the scan time equation. TR times phase encoding steps times next. Here's a phase wrap with the knee, with the foot, with the L-spine, with the hips wrapping in on either side. And you can see a little bit of motion too from the abdomen. All right, chemical shift. Chemical shift is an artifact where you have a difference in the processional frequencies between fat and water. What is our chemical shift for a 1.5 in that magnitude? 220 hertz. What's one at 1?
147.
147. What's it at 3 Tesla?
440.
Okay, just remember those. There is a rhyme and reason to it. Obviously, 220, double it, it's 440. And then if you take 1/3 of 1.5 and take 1/3 off of 220, you get 147. So just remember those numbers because you'll be constantly asked that on the registry and on my test. So make sure you know the chemical shift at all Tesla strength, especially those 3. So chemical shift happens when we have a very narrow receiver bandwidth. So anytime you have a structure that has fat and water, and it's usually at those interfaces of fat and water. So you'll see this a lot when you are looking at axial abdomen. You see the kidneys. Kidneys is a very common spot where you'll see this chemical shift. So what's happening is fat and water, you're getting a loss of signal on one side and an increase of signal on the other side, where that chemical shift is happening. So if you have, let's say, a receiver bandwidth of 16,000, which was our example, our chemical shift for that was about 3.5 pixels apart. So imagine these are the pixels. I know these aren't perfect squares, but that chemical shift is about 3.76 pixels apart. So one side is going to be dark, and that's why you have that dark band on this side of the kidney. And then the other side, I don't have white, but here's white. It'll be light. Okay, so that's what's happening here. So to remedy this chemical shift between our processional frequencies of fat and water, and remember, see how there's that interface between water and fat. Water from the fluid in the abdomen, fat from the kidney. So to remedy this, we widen our receiver bandwidth so that now this chemical shift gets closer together to the point where it almost completely eliminates it, where it goes into the same box, the same pixel. So if they're right next to each other, it's not going to be as noticeable. But if they're so close that they're actually in the same pixel, the white and the black obviously make gray. So then you won't even see that chemical shift at all. So chemical shift increases. Oh, that's still on white. Chemical shift increases as our field strength increases. B0. Our stagnant field strength increases, our chemical shift increases. So that's why if you're working on like that Hitachi at Resurgence Roswell, they don't ever have to worry about chemical shift because their field strength is so low that it won't even be an issue. So you really only kind of see these things on 3 Tesla magnets because a lot of times 1.5 is still not even strong enough to see a lot of chemical shift. So if you scan at lower field strengths, but if not, increase our receiver bandwidth, widen it out, and it will reduce that chemical shift. Going back to the chart, make sure you know how to do a calculation or how to actually get the pixel shift depending on what your receiver bandwidth is and what the field strength is. Okay, so you should have 3 different things in the equation. You should have a field strength, which gives you your chemical shift because you know it's 220. You should have the frequency matrix. So here, 256. So you take your receiver bandwidth, 32,000 hertz, divided by your frequency matrix, which was 256. Okay. And what's that number? I can't remember. It's like 125. 125. Yep. And then you take 220, which was our chemical shift at 1.5, and divided by that number that you get, 125, and that equals your pixel shift. So this number right here should go down as your receiver bandwidth goes up. Okay. So
You said we need our field strength and what else?
Field strength, your frequency matrix, 256. And your receiver bandwidth. That should all be given to you in the equation. Okay? Then you can calculate what your chemical shift is. Okay? So, remedies, scan at lower field strength, keep field of view to the minimum, increase receiver bandwidth, or just saturate out fat or water. All right, next one we talked about chemical misregistration. Once again, this is one of those things where you're dealing with fat and water, which process at different times. So sometimes they're going to be completely out of phase, meaning one's going to be pointing towards the 3, one's going to be pointing towards the 9 o'clock. And when that happens, you get pixels that are going to be completely dark, because we're not going to get any signal from those pixels where fat and water are in the same voxel, and then they're at opposite phase positions. So you get completely dark signal. So what it creates is that black ring around all of the major organs and bones and things like that. Okay? So we actually sometimes utilize this to visualize certain pathologies where we actually set our TEs at different times because we know they're going to be in phase and out of phase at different times. So here's an in phase image, and here's the out of phase image of the same slice. So this is called the Dixon technique. He was a radiologist here at Emory that came up with this particular technique. So we're looking at fatty liver and adrenal adenomas in this particular sequence. So this registration, look at that ring that, you know, your coloring book where you do the outline first. Looking at that ring, all the bones here have a dark ring border around it. Here's the fetus, but then it has a dark ring around it. All right, gives. Once again, we are undersampling the data. This is where we get high intensity bands that streak across the image at interfaces where it goes from really high signal to really dark signal. So we have undersampled the data once again. So we go back to our drawing a K-space. And remember, we said the signal and contrast is usually in the middle. And then we have the resolution at the outer ends. So what happens here is usually we have higher amplitude towards the center. So usually our signal looks like this. Oh, I can't draw this now. And then it peaks, and then it goes back down. Usually we have higher signal amplitudes in the middle of the K-space, and then as you go out, it kind of goes like this, and then it peaks just a little bit, and then it goes down. What's happening here, because you have high signal and then dark signal, is this high peak is getting pushed more and more towards the edges. So it looks like this. Now, towards the end of K-space, we still get a high peak. So then now it's basically putting that high signal in. Once again, if it's encoded in K-space wrong, it's going to be encoded in the image wrong after it's gone through the fast Fourier transformation. So now this high signal, which is supposed to be just resolution, gets streaked across our image. Okay? So to compensate for this, we just add more phase encoding steps so that this high peak here is still once again in the center. So we just add more phase encoding steps. So the remedy for this, increase your phase encoding steps. That's really the only, or increase your nets. Really the only remedy.
The white lines, right?
Yeah, these white lines, these things right here, streaking across. These ripples. So Gibbs, also called truncation. Gibbs also is called truncation. Your phase matrix, which number is it? Like if you had a 256 by 128, which one's the phase? 128, the smaller number. So a remedy would be go from 256 to 128 times 128 to a 256 by 256. So now we've increased those phase encoding steps. Here's what it looks like. Yeah, sometimes you gotta zoom in to see it. Here's on the phantom what it looks like. And this can be mistaken for Syrinx. So they asked on the test a common pathology that is actually an artifact. That's what it is. Gives it look like a Syrinx. Because look at how we go from dark to bright really quick. So this interface of dark to bright from the CSF to the spinal cord is causing that ripple effect to go through the spinal cord and make it look like pathology. So increase our phase encoding steps. You can kind of still see it a little bit, but it's not as big. All right. There it is again. Magnetic susceptibility. Remember, if we put any ferromagnetic object in our board of the magnet, our flux lines are going to alter. They're not going to be uniform anymore. So anytime you mess with the flux lines or our gradient slopes, remember our gradients, when we turn them on, typically are linear. But if we have a random ferromagnetic object come into that linear gradients field, it's going to cause it to, distort in an unpredictable fashion. So here, obviously, metal from the mouth, could be dentures, could be braces, it could be gold tooth, baby with a bullet, it's tragic. Rotator cuff injury on the coronal shoulder, sagittal knee, Could be an aneurysm, or it could be a hemorrhage in the brain. So remember, you have iron deposits within those blood deposits. So sometimes we use our gradient echo pulse sequence to increase the visibility of these iron deposits. So anytime you see this where you do have little spots of dark, we use that T2 star, that gradient echo pulse sequence, to really see those infarcts or those hemorrhages within the brain. So we actually use this magnetic susceptibility artifact to our advantage sometimes to see pathology. But that's only visualized on gradient echoes, because our spin echoes, like our stirs and our fast spin echoes, they have that 180-degree refocusing pulse that compensates for this artifact. So it's not going to be visualized as well. We talked about cross-excitation, right? Which one did we get to? We talked about crosstalk, and that was it, right? Okay, so crosstalk, most common in the L spine because we're overlapping our slices. So if you have two slices overlapping in some fashion, I guess I can angle my slices here. So if they're like this, and then remember our spine typically with something like this on a sagittal. So obviously our spinal canal here, just posterior to our vertebral bodies, we're kind of okay, but we're starting to get close to where that crosstalk artifact is. That crosstalk artifact is happening right where those two slices happen. So imagine we have our longitudinal axis and our transverse axis. So once we excite one slice here, so the hydrogen protons within this kind of area right where they're meeting, we flip it 90, and then now there's another slice happening, so it flips it another 90, and remember what's happening at 180. It gets completely saturated. So no signal from that area. So there's no remedy for this. So if there's a question on it, there's no remedy. The only remedy, I wouldn't say remedy, the only way to not have this artifact is not to position your slices on top of each other. So there's no remedy for this. Bless you. Here's another, that's going through the spinal canal, definitely going to repeat that sequence. Alright, so cross-excitation. So once again, we're dealing with saturation issues, but here, normally we're acquiring slices 1, 2, 3, and just going down the brain, right? So imagine this is 1, 2, oh, they already have the numbers on there, 3, 4. Ideally, we would want slices that look like this, where it was a complete rectangle, where one slice would end, and then you would start the next slice. But what is really happening, due to inhomogeneity, different factors within the magnet and the patient, our slice profiles have this curved shape to it. So at the edges of those slices, we get this overlap. So just like with crosstalk, we're almost applying 2 RF pulses to some of the slice. So what happens when we apply 2 RF pulses to certain spins? What happens to it? 2 90-degree RF pulses. Full saturation. So that's why on slice 2, right here, doesn't it look a little darker? Mm-hmm. You see that? We're losing signal. So our signal on SNR on slice 2 has gone down due to saturation. Okay? And then we get another bright one, and then we get another dark one. So here we have saturation issues. So it's really hard to see because you're not going to see on one particular slice an artifact, But you'll see on slices that are, you know, even and odd of each other, where you got one slice that's kind of bright, higher signal, and then the next one got lower signal, then bright signal, then lower signal. So cross excitation, you have to have multiple slices to be able to see this artifact. So you have to be able to flip through your sagittal brain to see this artifact. So a remedy for this, and you guys set this all the time on your console, is what?
Gap.
Gap. Gap. So usually you want about a 30% gap, 30% of our thickness. So if our slice thickness is, let's say, keep it easy, 1 millimeter, what's our gap? 0.3. Yeah. What if it's a 5 millimeter slice, which is typical for a brain? How do we get the gap? How do we calculate for that? 1.5. So 5. Somebody do the quick converter. 5 times 0.3. 5 times 0.3. 1.5 sounds. It sounds good. Yeah. Yep. Somebody's good at math. And then you guys, and that's why you guys generally see those 1.5. So distance, you know, distance between the slices, sometimes it's called. The slice gap, we need 30%. What's another way that we can remedy for this? Adding concatenation, or interleave. So remember, we could acquire slice 1, 3, and then go back and acquire slice 2 and 4. And then obviously you can see between 1 and 3, we have all this room here, so they're not going to overlap. So that's what interleaving is. So if you guys see motion on your brain, I think I was with Keisha, she was just observing, but we were doing a brain, and there was no motion on one particular image. But as you flip through all the axials, it looked like the patient was just going like this, you know what I mean? And so what was happening is, during the first run through, the patient wasn't moving on slices 1 and 3. But then, right before they started scanning slice 2, they repositioned. They didn't move throughout the scan. They just, you know how some patients they'll be sitting there, but then they'll just kind of have a quick little moment, and then they'll settle again. So that's what happened, and it just, because there wasn't motion on one particular image, but as you flip through them, they were doing this. Okay, so that's what's happening. Lily, you got a question?
Yeah, so how do you do the concatenation?
So on the Siemens scanner, you can actually increase your concatenation.
Oh, it's like it.
It's just you go from 1 to 2.
There's like a little box on the bottom, I think the bottom right.
Yep. And then with your GE scanners, remember you are constantly doing that calculation to try and get the best, you know, number of slices times concatenation, and it gives you like a good PR. That's how GE does it. It's like that little math conversion you have to do at the very end. Okay, so that's the GE way of doing it. But the Siemens obviously is more user-friendly in general, and they make it easy. So if you get that SAR, you guys ever have the SAR limits come up? And it's like, all right, what do you want to do? You want to change your TR? You want to change your number of slices? Or do you want to change flipping? Yep. You don't want to change your number of slices. Your best option would be the flip angle, but if it's like a 90 originally, and then they're giving you the only option like 10 degrees, you're like, no, don't make a drastic change here, because that could change your contrast. TR would be, but remember you have to stay within your TR ranges for that particular pulse sequence, so if it's a T1, you don't want to go past 700. So sometimes you need to reopen it. So like all those options they give you, you don't like. Even if you hit first level, you don't like any of those options. So the best solution to like minimize the SAR is bump up, go one concatenation up, because remember it's acquiring it, and then it takes a little break, and then it goes back into. So it reduces the SAR by that having that little break. So then you bump up your concatenations, and then you can adjust your TR appropriately. Okay. So this artifact, once again, is not visualized on one particular slice, but see how that our image quality has gone down here. Look at, we don't have as much signal. You can't see the white and the gray matter. Visualize that as well on this saturated slice compared to the normal slice. So if I have a question about this artifact, I'm going to give you several slices. So that's a way to clue in. Oh, all the other images just have one slice. This is multiple slices, so it's got to be cross excitation.
So this only happened in one slide over time, or?
No, I'm saying like it happens, you can only visualize it as you flip through your slices.
Okay.
So like, see how Lily, you can't really, it's like if you just had this artifact here, just this image right here, you can't, look at it, you can't see anything, right? I mean, it's not the best image, but there's no motion, there's no gives, there's no metal. You wouldn't be able to like say definitively that there's an artifact. But if you are given both images, you now can say, oh, this one has less signal due to saturation. Okay. All right, zipper artifact. It's finally something that we didn't do wrong. Well, maybe. So this is random RF energies coming into the room. They could be coming from, honestly, a radio station. Because remember, we're dealing with radio frequencies for our RF pulses. So if they match the radio frequencies coming from your magnet, and they have linked into the room somehow, remember, that's why when we talked about MR safety and equipment, we line the room with what?
Faraday cage.
Which is made out of what? Copper. Copper basically prevents any of those extraneous RF pulses getting into the room. And that's why they even that's why MRI doors are so hard to get open, because they line the doors with those copper teeth so that the random RF energy doesn't get into our room. It could be even from a light bulb that is, blown out, and it's just like the little fuse of the light bulb, the wiring of the light bulb come from that. So if you see an RF pulse in your room and you've checked the TP door, you've checked all the monitors, like in the department, zone 3, zone 4, nothing is like random there. Sometimes the next thing they check is the light bulbs in the room. If one has been blown out or it's not malfunctioning, that could be causing the RF pulse. So what it looks like is this zipper artifact. You can see how it just like little dots across the image in your frequency direction. So remember your directions, your frequency direction.
Can you say that again?
Which direction? Frequency. It's on the chart too. It's RF pulses leaking into the room, and it looks like a zipper, just like in your pants, a zipper artifact streaking across the image in the frequency direction. So if you image it again and you change your phase and frequency direction, and now this zipper artifact streaking across our image this way, so now it's streaking across our image this way after we change our frequency direction. You know that's a zipper artifact. It's nothing we can compensate for unless we find that random RF pulse energy and turn it off, eliminate it somehow. So it's happened to me before. We had just a EKG monitor that was outside, and there were the MRI safe ones, and it just, I guess, since it was on most of the time, it just was producing this. So we had to, basically, there was a couple of teeth that were missing after wear and tear over the years. We had to replace that, and it eliminated it. frequency direction. All right, shading or dielectric artifact. So going to your chart, scroll on down, and let's look at, so remember, it's got two names, shading, dielectric. These are caused by local eddy currents due to increased conductivity of body tissue. So remember, when you are positioning a patient, you don't want them to be looped in any way, right? Because if you loop in a magnet, it can create what?
Burn.
Birds?
Burns.
Burns. It could create burns where you're touching, yes. So you could basically create a shock voltage within the patient. So, when, you're positioned for a lumbar spine or an abdomen, people tend to just do stuff like that or like this. Don't allow that to happen because you're creating a loop. Anytime you have a loop within a magnet, you can create a voltage. So what's happening here is it's really not the patient. They could be touching in a particular area, even as simple as maybe having their arms by their side. But it's really dealing with the patient touching the coil. The coil should not be touching the patient. You should have foam pads or some kind of sheet between the patient and the actual receiver coil. Or if the patient's rubbing up against the bore of the magnet. So that's why you put those nice padded foam pads the length of the board so that you prevent this shading or dielectric artifact. So it's basically an abnormal loading of the coil. So if you actually, sometimes you put those coils in and they're not engaged appropriately. So always look at your scanner, because sometimes it'll tell you that, that coil's plugged in appropriately. Sometimes they're half plugged in, not completely positioned right. So what's happening is abnormal loading or coupling of the coil at one point. So if the coil, if you have your big abdomen coil, if it's not touching on this side, so you can, sometimes they're a little off balance, and then it's touching on this side, it creates that shading artifact on that particular side because it's inducing a voltage. So the remedy for this one, these are just patient prep remedies. Use the right coil size. So if you're doing an ankle, obviously don't use like the abdomen coil. Use foam pads in between the coil and the patient, in between the patient and the bore of the magnet. Use those foam pads. The coil should not be touching the patient. Even as thin as this could prevent these shading art as long as there's something. So like sometimes just the gown will help. So that's why you're like, I never see them put that many foam pads on like their abdomen because usually just the sheet and the blanket, that's enough to separate the coil from the patient so it doesn't couple. But like for a shoulder coil, do you guys ever see them put like a little pad there to make sure that they're not actually touching the coil? That's to prevent this artifact. And also, anytime you do have the shading or coupling, if you try and fat sat, you'll lose the fat sat. So if you have like a shoulder, wherever they're touching that coil, it's harder to fat sat because it screws up your homogeneity. So and then breast coils, like when the patient's laying down, typically where their chest is hitting that coil right here, you'll lose the fat sat. And on the other they'll lose the fat sat. Okay? So breast imaging is hard to get a very uniform fat sat because of just they're touching the coil. So remedy shim. Coil shouldn't touch the patient. Coil should be loaded correctly. Use foam pads, and then once again, make sure you're shimming. Your GE scanner, you always put your shim coils on your fat sat. Siemens, they automatically do it, but you could always bring up your shim coil if you needed to, just to see where it is. Remember, you only shim on tissue, you never shim on the air. All right, last two. So, let's show some images first of shading. This is not the best one. I guess, this side of the patient right here, you're starting to lose some signal. obviously this is a C-spine, so they probably didn't even put the anterior coil here. So that's just a loading of the coil issue. But here, if you can kind of really see, let's zoom in a little bit. See how the right side of this patient right here, you have those erector spinae muscles back here. See how the right side is darker than the left side? See that? So the coil was probably loaded, that flex coil was probably somehow like touching this side, and then it like floated up on that side. It could be as simple as just having those straps being too tight on this side, and then they were too loose on that side. So just when you put those coils on, make sure it's like even. You know, don't have it looking all wonky and wobbly. Making sure it's very uniform. All right, zebra. Obviously, the name kind of gives it away, right? So you get these areas of it phase in and out. So remember that in and out imaging where we got those dark bands that surrounded the organs? Well, what's happening is this is a combination of that in and out, because this is a gradient echo, very fast pulse sequence. And then also, what is outside of this image here that is usually laying right against the side of the patient? Their arms. So it's a combination of two artifacts, the zebra. It's misregistration and oversampling, or phase ramp. So zebra is really a combination of two artifacts. Those artifacts are phase wrap and chemical misregistration, which is your in, out, in and out, or your Dixon technique. And these usually happen at the edges of the field of view. So once again, you're undersampling the data, do the phase wrap, and then it's a gradient echo pulse sequence. So anywhere you get fat and water, those interfaces, you'll get this chemical misregistration. So you're combining two artifacts to create this zebra effect, also called moire, French. So back to the little asterisk on there. So here you can see a combination of wrap and field inhomogeneity and a gradient echo. This inhomogeneity causes the wrapped arms to be in and out of phase, causing that banding appearance at the edges of the field of view. So black and white, edge field of view, always seen in gradient echo imaging. And you know, sometimes we just do this coronal of the abdomen just to set up our slices for our axials, right? So are we really concerned with like eliminating that artifact? No, because it's really just, it's almost like another localizer scan. Because we're not really, the radiologist isn't going to, they'll look at it because they might find an incidental finding like in the heart or something, but you're really just setting your slices up for the coming scans. So then you obviously get above the liver all the way down to below the kidneys. So then you just make sure you have slices over the liver all the way down below the kidney. So this is a quick, could be a T2 sequence, which remember is our normal just free breathing technique. So we still get that artifact, but it's not really as big of an issue because we're really more concerned with the axial slices in the abdomen than the coronal.
So this artifact doesn't show up on the axial slices?
Nope, because we don't worry about the arms wrapping in on the axial slice because we go A to P. Okay? But we do get chemical misregistration, the banding, on that in and out phase, but we actually do that on purpose. So sometimes we actually cause an artifact for pathology reasons. In and out phase is one, and magnetic susceptibility is the other. When we're actually utilizing an artifact to see if there's a pathology. Here again, you can see just a very, look at low signal image. So you know it's a gradient echo, and then you get this banding or zebra artifact near the edges. Look at the arms. They don't know what to do with these arms. They're just going to show up. This patient has a huge spleen. Something's going on. It's pushing, look at it. It's pushing the left diaphragm higher than the right diaphragm. All right? And then you actually get sometimes these different fabric-looking artifacts. And this is basically causing, there's a little issue with the receiver coil and how it basically is collecting the signal from the receiver coil. This could even be from static discharges. So once again, if we induce a voltage in the patient, it can cause these corduroy, canvas, tweed artifact, all these different fabrics. So if you see these fabrics, it's really these what we call multiple noise spikes. So it's kind of an issue with the receiver coil and the analog to digital converter. So, these ones we really can't compensate for. We need to get an engineer. So if you see like the fabric things, that's an engineer issue. So you can read here exactly what's going on with these noise spikes. But once again, it's not really something that we can compensate for. So that's why I didn't really list this one on the chart. All right, last one. Magic angle. So if you, they may call it the magic angle because if you're just that unfortunate and you get this artifact, you're just having a bad day. So it's an artifact that is caused. Let's see. Let's go to the chart. This is seen as in tissues that contain collagen, like our tendons, as high signal intensities. This is basically causing a high signal intensity when we're using a very short TE. So once again, it's a gradient echo pulse sequence. And this high intensity within the tendon may mimic pathology. It may look like a tear or a slight tear, things like that. And it's so random because this T2 decay time increases when collagen-containing structures lie at 55 degrees for the static magnetic field. So you just have to have bad luck when you are positioning that patient that randomly that collagen-containing structure, it happens to be perfectly at 55 degrees of the static magnetic field. It's the same in both the phase and frequency direction. So to remedy, just change the TE slightly or reposition that knee or the shoulder or whatever now you're scanning so that you don't get that arc. So magic angle because you're just having a bad day. So here's the static magnetic field. This is a sagittal. So once again, you're laying along the length of the bore of the magnet. So you can see here, this is B0. And then that collagen-containing structure right here, right where the patella tendon is attaching to the tibia, it increases our T2 decay time, causing it to be correct. So you can see it is here. be 0, 55 degrees right here. So it could look like a slight rotator cuff tear on the shoulder. Once again, bad luck. And then once again, here is that 55 right at that patella tendon. So this is a stir. We have increased signal within the tendon. And look at it, it increases the signal almost past where the entire tendon is. So that's a way to kind of recognize it. Because that signal should be contained within the tendon if it is just a tear. But see how the signal is almost on either side of that tendon there. So just reposition, just change this TE slightly, get rid of that. All right, and then here, this last slide is just a good summary of the artifact, the axis that it occurs on, the remedy, and then sometimes when you remedy things, it has a penalty associated with it. So if you increase your nets to get rid of that motion artifact, you're increasing your scan time. So, you know, with MRI, there's that constant balancing those three things, right? The signal, noise, your image contrast, and your scan time. Do you guys have any questions? Is there any questions about your chart? And once again, feel free, take this to clinic, because it'll come in handy if you have an artifact and you know, you need to quickly reference how to get rid of it. All right, so get your phones out, and we will play a shot hoop. So this will help you be able to identify the artifact. So this is all about just looking at an image and saying, what artifact is it real quick? Anybody got the new iPhone? Yeah. All right. All right, so you got 20 seconds. Look at it and tell what it is. 23. Alright, crosstalk. Going through that spine. Gives high and low signal intensity. Frequency wrap, remember, the system automatically compensates for that. So you should never see frequency wrap on a test as an answer. Zipper, frequency direction and random RF getting into the room, leaking into the room. Rotator cuff surgery. Magic angle. 55 degrees. Sad, very good. They all need to be named like this, right?
Yeah.
Like, so that's a good indicator. We need to like come up with other names for the other ones, like that are like characterizing. We should call gives like wave ripple or something. Black on one side of the kidney, light on the other. If you have multiple slices, you know it's cross excitation. Don't remember the other name for it, huh? Phase wrap, aliasing. If I put phase wrap up there, everyone would have got the other name for it, aliasing. Gotta know the other names for it. Out of phase, and this registration is also called out of phase. Well, I kind of lied because it was multiple slices on that one, but you got the point. There was a dark band at the bottom. bottom of the vertebral body, and then there was a light band at the top of the vertebral body. And that was in the frequency direction. Frequency direction was going head to foot. Ripple artifact. Zebra. Moray. Knee replacement. What's the angle? 55. Ghosting, phase mismapping, motion, all the same artifact. Nobody got it right. Motion of the head. Phase mismapping, ghosting. Last one. Good. Nobody was tricked by that dark signal within this time. Right. Alien Halloween theme, I like it. All right. So you guys can watch this back for review, whatever you need to do to study for the test. Highly recommend just looking over this. Remember, know the image appearance. It's all the PowerPoint of all the images I provided. Know the alternate names and the direction. Either it's phase, either it's frequency, either it's both phase and frequency, or even the slice direction. Those 4 options. So know those. And then I just need to mention one other thing. So there is another artifact. This artifact partial volume. This is where pathology is missed because of low spatial resolution. Okay, this occurs in both phase and frequency. What it looks like is you could possibly just miss pathology, low image quality because our crappy resolution. Remedy, increase matrix. Decrease field of view while maintaining matrix. Increase phase encoding steps, which is also the matrix. So basically we want a smaller voxel. So imagine we have a voxel this big. Okay? Pretty big voxel, not going to have very good image quality because our resolution is so bad. Imagine we had a pathology. That pathology is a tiny malignant lesion. It looks like this in the brain. So our brain is obviously huge compared to this tiny little voxel, and this was that little malignant lesion within the voxel. So what happens is for any signal within one particular voxel, it averages that signal together. So the signal coming from the pathology and the signal coming from the brain tissue get averaged together, so it creates just a standard gray shade. So due to these two signals being averaged together, what this particular voxel might look like is just a shade of gray. And that gives nothing for our radiologist. So to improve this and maybe see this particular pathology, we just now increase our matrix. So even though we're still averaging these together, where you'll have an edge of pathology and then mostly just normal brain tissue, this will give us a certain shade of gray. So this is some shade of gray. But then these right here that have more pathology will be a little brighter. So now that we're able to differentiate the signals from voxel to voxel, the radiologist will be able to tell that there's a pathology. Okay? So that's partial volume part of that.
So how do you know that you're missing?
Sometimes, I mean, if it's so small, hopefully it's not a pathology that's not going to be affecting it, you know? And pathologies grow over time, right? So that small metastatic lesion in the brain might not be like, say you have breast cancer, and people with breast cancer sometimes get brain MRIs like on a yearly basis to see if it's metastasized. And maybe on the first year out, nothing showed up because it was so small, because our slice thickness was 5 millimeters, it was averaged into those slices. But then a year later it grew, and then now our 5 millimeter slices can detect it. Okay? So sometimes it's so small it's not going to really do anything, hopefully, but it could be leading to something bad. Okay. I mean, MRI, we get good image quality, we get good resolution, we have great images, but sometimes pathologies are so small we're not going to be able to do that. And we just, you know, hopefully that's a good thing, because they're so small it's not going to cause any issues. So let's take a break, and then we'll go